Good. Okay, so we are official, people. We're recording and we're live streaming. As I mentioned to the panelists, just if there's any questions that you have while we go, just put it in the chat box. Okay, guys, welcome. This is an extremely unique initiative by the Resource Optimization Network and our podcast, Solving Healthcare, getting some of the great critical care minds to discuss about the prognosis of our vented ICU patients. And this has really been initiated because of the JAMA article that came out April 22nd, looking at overall prognosis of COVID patients, but specifically, there was a high mortality rate associated with patients that were mechanically ventilated or put on ventilators. And so we wanted to see globally amongst our colleagues, is this what we're seeing? Are we seeing mortality rates greater than 80%? And this got in the press, and there was a real sense, at least for me, of anxiety that this was going to be, this was going to affect care. With such an highly respected journal producing this content. So I really want to thank our guests for joining us. I'm going to start with, we got Dr. Hayley Gershengorn, Associate Professor and Interim Vice Chief of Pulmonary and Critical Care at University of Miami Miller School of Medicine, and also a Harvard graduate. This might be the first time I'm talking to a Harvard Medical School graduate. What's up? Thanks for coming. My man.
Thank you for the invitation.
100%. My man and Resource Optimization Network member, Bram Rochwerg, Assistant Professor, McMaster's Division of Critical Care, and Site Chief, if I'm not mistaken, of Juravinski's ICU, and monster researcher. We were just looking at his numbers. They're ridiculous. Thanks for joining us.
Thanks, Paul, for the invitation.
100%. Anand Doobay, my man. We went to med school together, and he is the head of medicine over at Markham Stouffville Hospital, intensivist, also media mogul, and showing up on the national and stuff. Thanks for joining us, Anand.
Thanks for having me, buddy.
Absolutely. Peter Brindley, podcast guest times, it'll end up being times 2 or 3 by the end of the year, but Professor of Critical Care Anesthesia at the University of Alberta, nature enthusiast. I just love, I'm a big fan. I got a man crush on Pete, so thank you for joining us.
Nature enthusiast rather than naturalist enthusiast. There is a difference.
Thanks for clarifying. My boss and super, I'm going to say really been a great leader during this time, actually. Dr. Dave Neilipovitz, head of ICU, been leading the charge within our region for management of COVID, and also an anesthesiologist. Thanks for joining, Dave. And
thanks, Claude.
Absolutely. And I'm going to say guest of honor, Dr. Tommaso Mauri. He's the internist and researcher at the University of Milan. And, especially knowing the kind of volume that was seen in your country, and you taking the time, I think we could learn a lot from you. So I really appreciate you taking the time.
Thank you. Thank you for inviting me.
100%. So where to start? I got kids crying in the background. I apologize. There's 3 kids here, and it's like, oh my God. We're going to start with Tommaso. Maybe even just from the beginning, what it's been like taking care of COVID patients, what you saw at the beginning, and what the state of the affairs are now, and how are your patients doing?
Okay, thank you. In Milan, the let's say epidemic and the surge of patients into the ICU became huge and not under control, outside of our control at the beginning of March, end of February, beginning of March. And in 2 or 3 weeks, we filled all the ICU beds we had in our region, Lombardy, Milan, and the surrounding area. And we had to open new ICU beds at a pace that was like from day to night. There was one new ICU in my hospital. For example, my hospital used to have 2 ICU, and ended up having 5 ICU with around 60 to 70 patients intubated in the ICU, COVID patients at the same time. So by the end of March, we had like 60, 70 COVID patients coming from all over the region, very severe. No bed in the ICU was with a non-invasive or non-intubated patient. All the patients were intubated. In the beginning, we are an ECMO center. We decided that it was too much to start on ECMO these patients, and we didn't do much in the beginning. In the second half, let's say after the end of March, we started doing also some ECMO. But we did very few because the logistics and the amount of patient was incredible. It was we could not handle that. The other thing that is relevant, I think, is that a lot of doctors who came in the ICU to treat this patient were not intensivists, were not maybe they were trained as intensivists but never practiced the intensive care unit before because the patient were too many. So this was the situation by the end of March. 60, 70 patients looked after by, I would say, a third of the doctors that were intensivists and 2/3 of the doctors that came from either the operating room or the medical wards, and a very severe patient. And in the beginning, this was ARDS. So we treated them as severe ARDS patients, elevated PEEP, proning, but there were, I perfectly remember, 2, 3, 4 cases, Matthew, dying without having us had understood anything of what was going on with this patient. They had very high D-dimers, they had pulmonary thrombosis, they had very high dead space, very low PO2, and they died suddenly by cardiovascular collapse, I would say. Very young patients. This was in the beginning. I think that with time, we are a research center. We did a lot of measures in this patient. We published a paper in Critical Care Medicine. And with time, we kind of understood a little better the physiology of this patient. And we tended to use less PEEP and proning. Maybe at a later stage, we used NO, inhaled NO afterward. And I think that those sudden deaths didn't happen in the second half of the crisis, let's say after April. But I would say that you started with the prognosis. I think that we discussed with my colleagues this, and we can divide roughly schematically patients, I think, in three outcomes in the ICU. There were those that in a few days improved and could be weaned. There were those that didn't improve and had sudden death, shock, cardiovascular collapse. And the third group is very severe that ended up having prolonged weaning. And we still have those patients now in the unit. We have a patient that is there since 2 months. And I think that in a week will be weaned from the ventilator. So those with the prolonged weaning had a lot of pneumothorax, very low compliance, and it's taking a lot of physiotherapy and support to take care of this. And they have like 30, 40, 50 days on mechanical ventilation, but they are recovering. It's not that they are. So I think that these are the groups. The mortality, we don't know yet how much it is. There was the first publication in JAMA from our group, and their mortality was 25%, but was very early days. Now the mortality, my feeling is that is no more than 30-40%. So it's similar to severe DS. But the days on ventilation are much longer than standard ARDS, I would say. And the last thing I would say is that these three groups, the sudden death, the prolonged weaning, and the easy ones, were, in my opinion, impossible to differentiate on day one. They were all as severe between them. Very low PF ratio, very high PCO2. There is some correlation maybe with the days from starting of the symptoms, but not very strong in our experience. So this is our experience.
Wow. No, thank you so much for that lovely summary. And I got to tell you too, like we learned a lot from your guys' experience. Like I think our success rates were completely related to knowing that, you know, seeing what you guys saw and being able to articulate, hey, yeah, there's more clot burden, there's more renal dysfunction, there's maybe different ways we should be approaching ventilation. I think was in my opinion vital to the success. So Hayley, maybe you could talk about what the experience was at your site and comment on Prognosis as well.
Sure. I think, you know, in a lot of ways we were very fortunate. Many of them relate to the fact that places like Milan and all of Italy, and then certainly within the US, New York, were sharing their information with us. And so while we did see an uptick in cases, it obviously looked nothing like what was just being described. So I worked at two hospitals in downtown Miami, one of which is a more smaller, was typically a private hospital, although it was converted into an academic site, and the other of which is the large county hospital for the city. We normally cover both hospitals in the ICUs, but we've divided our faculty for this. So I worked primarily actually in the smaller hospital, and so I can probably speak a little bit more in detail about that, although I can try to mention the other one as well. So again, our peak, for what it's worth, was certainly much lower than what was just being described, and certainly much lower than other areas in the US, but occurred probably around 3 weeks ago. And our census in the ICU on the medical, in a very typical US manner, our ICUs and tertiary care centers are separated, right? Medical, surgical are all somewhat different. So the medical ICU census, which is where these patients largely found themselves, really went up probably twofold at most. So our bigger hospital normally covers about 26 to 30 of these patients, and probably had closer to 45 to 50 COVID patients. Not all of whom were intubated, but many of whom were. In the smaller hospital, we usually have about 10 or 15 medical ICU patients, and at our max had about 19 or so COVID ICU patients. But again, I think we really did learn from a lot of what was just being described. So we were able to upscale quite quickly. We created a separate unit in a number of those places, as you were just describing, very quickly. But we were able to do it with a lot of lead time, I think, because of the experiences around the world. I think we didn't see as much as what was just being described of this sort of low or normal or higher lung compliance ARDS, or acute injury. I wonder if that's in part because since we were a little bit delayed and we were hearing from other places that there were maybe not as much of a need for the sort of early intubation strategy, that maybe we were really only intubating folks as they became kind of more traditional ARDS. I'm not certain. I will say most of the folks that I took care of had fairly compromised lung compliance and seemed to respond very well from an oxygenation perspective to higher PEEP and proning strategy, similar to what you might see in typical ARDS. We're certainly seeing a decent number of the clots that were just being described. I also wonder if we're looking more than we do for our other ARDS patients because of what people have been describing. And I think that overall, our outcomes obviously are still up in the air, but I similarly think that we're going to end up seeing very similar to typical severe ARDS outcomes. The most recent numbers that I've seen, at least at one of our institution, about 2/3 of our patients have a hospital outcome at this point. And about half of those have died, and about half of them have survived a discharge. So that kind of, if you think about that, that's sort of a third, and so I can imagine the overall mortality ultimately being in sort of the 30-40% range as well.
Wow, thanks for that, Hayley. Maybe Peter Brindley, the one and only. You're the only one representing the Prairie provinces, my alma mater. We were hearing a lot about Edmonton being quiet in terms of COVID numbers, but certainly Calgary, we were hearing the numbers were up. What did you get? What was the sense that you saw locally? You're muted, my friend.
I'm terribly sorry about that. Pregnant pause. I'm going to have very little to add to what your two experts just talked about. We have had a relative state of novid rather than COVID for the last couple of weeks. We haven't had an ICU admission for COVID to the two places I work in for over 3 weeks now, and a handful of cases before that. So the numbers that have been offered by your Italian and New York experts are similar to ours, that it's looking like once they get ARDS, and I don't know if we're going to get into a discussion of what seem to be the various subtypes and or time presentations of the disease, it doesn't seem to be massively different than ARDS. What it is a heck of a long time on the ventilator. So it's worth a good chat about whether the early approach, which was tube everybody, sedate everybody, paralyze everybody, versus what seems to have been the later approach, is try to keep them off ventilators, maintain them on dreaded technologies that might just aerosolize, that might cause aerosolized generating particles, or maybe the greatest thing, because you keep them off injurious ventilators. That's the position we're in. Because we haven't had a big first phase, we're almost certain we're going to have a big second phase. So we're eager to get it right when it comes around.
Mm-hmm. I hear you. So maybe Doobay, you were one of the, I think in Toronto, you had the highest volume of COVID patients initially over at Markham Stouffville. And when we talked offline, hearing about the prognostic, your results in terms of prognosis, I was actually quite surprised. So I'm wondering if you could articulate some of that.
Sure. So like Hayley said, we had the benefit of seeing what happened in other places. So we did have a long time, I mean, short, but relatively long compared to other places, time to prepare. So I feel like we were lucky that way, that we were able to manage a much higher burden of patients than we normally would have, which may have affected the prognosis in some cases, because I think, when you're under stress, obviously it's much more difficult to take care of some of these patients. So we're in a medium-sized hospital about 45 minutes outside of Toronto that normally has 15 ICU beds, about a 300 to 400 bed hospital. So for whatever reason, community spread happened sort of first in our region. So we did have one of the earlier waves in the end of March. Just to get straight to the point, I mean, by the end of April, April 30th, we had just around 30 cases that had come to our ICU. But for the most part, these patients have fit the criteria, fit sort of the description of most COVID patients. But for some reason, our patients have done fairly well, and I have really no explanation for that. We have only had a small percentage die so far. So our mortality rate is around 10 right now. There are still some to be determined, but it's not going to hit the 25 to 30% range, it seems. Of those 30 patients, 18 patients are already home, actually. So, and if you look at our PF ratio median, it's around 100 for the worst PF ratio during their stay. So they were sick, and in the beginning, I feel like after looking over all of these cases, because we're doing a case review, it seems if you look at the data that we were intubating them early, because if you look at their SATs, their FiO2 and stuff before intubation, you see someone on 6 liters who's satting 100% with a respirate of 24. You look at the chart, you go, why are you intubating that person? But we just started to have the experience as we tried to delay, that person would almost inevitably be intubated within a day. So we started intubating earlier, and then we moved to what Dr. Brindley was talking about. Of like, why don't we try high flow nasal cannula for a couple of days? Let's see if we can avoid ventilation. And out of those 28 patients, 26 of them ended up being intubated, and the patients that we tried to maintain on high flow nasal cannula, only 2 of them were successfully able to get through their ICU stay without requiring intubation, and we tried several in terms of trying to avoid intubation. I would agree with Hayley. They fit normal ARDS patterns for the most part. A lot of these patients were on very high peak pressures. We didn't see a lot of the high compliance patients. And the only other thing I would say that we noticed that I haven't seen a lot of is that because these are mostly healthy patients for the most part, we were really bringing mostly healthy patients to our ICU with very few comorbidities. Our median SOFA score was only 5. It seems that when they were coming off the ventilator, they were recovering very quickly from a physical point of view, a lot faster than I would normally see. And that may just because a lot of them were unusually healthy after getting to the ICU, but that's the other thing that we noticed. They were rehabbing very quickly and getting home. So, it's a different experience than a lot of places. We're still trying to work out exactly why. I don't know if we ever necessarily will, but I would say that over the past few weeks, our patients do seem to be sicker. They're not recovering the same way that the original wave seemed to be. They're staying on the ventilator longer. We've had more reintubations, more requirement to transfer to ECMO centers. So I don't know that there's necessarily something changing or if it's just a coincidence, because these are small numbers of 30 to 40 patients. But those are the observations I'd say that were the most pertinent to me.
Wow. Thanks for that, Anand. Maybe for Dave and Bram, I'll let you take turns here. Actually, Dave, before Bram pipes in, you got a lens from a higher point of view in terms of how we're doing regionally, and maybe just getting to the point, does this seem to be consistent with the numbers that we're saying? And then Bram, I was going to put you on the spot in terms of why do you think our numbers are in terms of prognosis are better compared to what was quoted in New York, and to other sites? So yeah, Dave, maybe let us know what you think.
I don't know if it's a higher point of view or is a larger point of view. Very similar to what was presented by the other series of speakers. Roughly for us, having a little more specifics, about 2/3 of our patients were vented. So I think we were much more aggressive at not intubating, and so we learned from the other sites. And so, rightly or wrongly, that is kind of what we saw in our region in terms of mortality, which is certainly the focus of the talk here today. We had a 30% mortality in our region, which is very similar to roughly what the province is reporting for vented patients. Overall mortality is closer to about 25%. And a lot of the patients in that type of grouping that ended up dying who weren't intubated, we certainly had some octogenarians, if I'm using the right, people in their 80s and 90s, which I'm not sure would have gotten into some of the ICUs that are overwhelmed. Certainly the talk of the triage and all the concerns surrounding that, but with our numbers not being as outlandish as what other centers were experiencing, certainly we did our best for some of those, that patient population group. We're actually doing pretty good in that 70% discharge rate is almost what we're at for our region, and 70% discharge rate alive, just to be clear on that. So for the most part, I think the numbers are very similar in Ontario and to what we heard. In terms of anticoagulation, I think we were very aggressive with that, and it'd be interesting to hear what others think, if that was a good thing or a bad thing, and whether or not that helped out. Dialysis rates were roughly about 20%. So those are some of the numbers. You know, I do believe we were more aggressive, like I said, in anticoagulating and maybe not intubating everyone. And so if we do a deeper dive on how sick everyone was, it would be interesting if we can compare, are we comparing the same patient populations or are they different? And just one last point is, we never saw any of that cardiovascular collapse that's been described, and certainly we heard out of Seattle. So I'd be curious to know what other centers, if they saw that or not, but we most certainly didn't. And I'm wondering if that's, to be honest, we didn't use a lot of hydroxychloroquine and some of the other medications, and whether or not that factors in at some point. And now we'll take a deeper dive, and I'll leave that question to be answered by Bram. We'll leave all the hard questions for him. But whether or not that it's the treatment that may be responsible for some of those unusual situations as opposed to COVID itself.
Yeah, sorry, Bram, we're loading you up with a big
Yeah,
one
no worries. Thanks. It's been great, great to listen even to this point, hearing about everyone's different experiences. And I do think that there's a bunch of different explanations for the variability in prognosis that we're seeing. And I think it's both, you know, methodologic reasons, but also patient characteristics and others. You know, some of those early reports that came out, a large proportion, as Hayley mentioned, of patients were still requiring intensive care resources. And, you know, some of the reports, especially the ones from New York, were only commenting on those that had an outcome at the time. And we've seen how long those that are sick with COVID ARDS persist in hospital, requiring mechanical ventilation over a prolonged period of time. And the ones that survive are going to need that time to overcome their illness. And the ones that you immediately have endpoints in terms of survived or lived, it's not a surprise that more of those died, and perhaps the numbers were artificially inflated. So I think that there's methodologic differences, but then also, as mentioned, patient differences. Definitely elderly populations perhaps have increased risk of mortality, and Tommaso perhaps can comment more, but from what I've heard is that region of Italy might have a higher proportion of elderly patients, and that might have contributed. We've seen that those risk factors for poor prognosis, from what I've seen, things like being overweight, hypertension, diabetes, and not a comment on the state of the United States, but I think that the prevalence of some of these conditions is higher, might also have impacted in terms of prognosis and even access to healthcare. You know, is that the United States does provide excellent healthcare to certain parts of the population, and then I'd argue not having a universal healthcare, that there's proportions of the population that don't have as good access to healthcare, and that might also influence outcomes in the United States as compared to other locations, or differences between locations as well. So. And then finally, as Dave alluded to, is when it comes to experimental therapies, my sense is that a lot more experimental therapies were used in different regions, or there was at least variability in these things. And as we know with experimental therapies, there's an equal opportunity for benefit as there is for harm until we have evidence suggesting that these should be used. And I had heard reports of people with ARDS from COVID in the United States getting 6 or 7 treatments on hydroxychloroquine, remdesivir, azithromycin, antivirals, convalescent plasma, steroids. And again, when you're giving 8 or 9 of those things, I think there's equal likelihood that you're perhaps contributing to harm as well. And I just wanted to end on one thing. I had an interesting anecdote, I think, of, the harms of perhaps misinformation around prognosis. And it was very prevalent that those that ended up on the mechanically ventilated with COVID, the prognosis was awful. There's no sense in even going on. When I took over service a few weeks ago in our COVID unit, we had a young gentleman, a 50-year-old guy, previously healthy, who was in our ICU with COVID. He was on high-flow nasal cannula and escalating doses. And the handover I got was that he was A&D. When they talked to him, he did not want to be intubated. When they talked to him and said, you're sort of heading that way, he said, well, listen, I heard from Donald Trump that as soon as you're intubated for COVID, that's it. It's a death sentence. You're going to die. That's what I read in the media. And he was refusing to be intubated. And so the first thing I did when I got handover was went to him and said, listen, like, this is misinformation. You're a 50-year-old guy. You're previously healthy. I can't guarantee you anything, but odds are if you get intubated, we're going to get you through this. Odds are. And had to convince him to go ahead for intubation. A couple hours later, he was intubated, and he ended up, this was 7 weeks ago, he ended up tracheostomy, and from what I heard was just weaned from the ventilator, has just come off, hopefully for good, who knows. But I do think that there's harm with diffusion of this information that is perhaps incorrect. And, maybe as epidemiologists, we understand that, but lay people, press, leaders of countries don't understand the limitations of the data and disseminate this false information, which can have monumental harms, I think.
Oh, I mean, essentially, Bram, this is why we're doing this, man. Like, there's been a lot of misinformation in general, and the narratives that you're seeing in the media is, obviously very negative and could be misleading, but this was a monster one. And this is the first time I heard of a patient saying no because of what's out in the media. But think about how dangerous that is. And this is thousands of cases globally, and you're seeing this firsthand. So this is exactly why we're doing this now. Peter, you look like you wanted to say something, unless I misread you.
No. I think we should get into the experimental therapies discussion. Bram, I would just caution your enthusiasm. Your patient is still going to vote for Trump in 2020 when he gets better. That's all.
Okay. Doobay, you were going to throw something?
I just wanted to say, so exactly what Bram said, basically. Like, it is really, I would say, clouded or influenced I wouldn't say all, but most of our discussions about goals of care in a good way and a bad way. Obviously the bad way, in where, Bram, I had a patient exactly like this, a patient who did not want to go on the ventilator, fairly healthy. I remember it. He had gout and hypertension. And he's like, no, I'm one of those patients. I'm very sick. I'm not gonna survive. And we had to, it's not often that we're convincing people to be intubated. It's such an unusual state, but there were people like that for sure. But it also influenced the goals of care discussions in patients who we actually don't feel should be intubated. It was a lot easier, which, I think for a physician who is having that discussion properly and for the right reasons is good. But there are potentially some physicians who don't have necessarily the same knowledge of what happens at the ICU and prognosis, who could take that information too far and actually convince a patient to be, yeah, you're right, COVID's really bad, like you really shouldn't go that way. And it might actually be the wrong decision for some patients, directed by a physician who's also being influenced by the same types of data that are coming out. So it's good and bad.
Yeah, I mean, and Bram's point too is if you looking at it with an epidemiological lens, yes, you could poke holes in the JAMA, but I know some pretty sound clinicians, intensivists, that were citing this as reasons why not to intubate people. You know what I'm saying?
I'd add a couple of points. There's a fascinating phenomenon in research where if you remove the first couple of patients from enrollment in some studies, you'll have a vastly different result. In other words, it's a bit like simulation. You have to get used to doing something before you can do something properly. And so that is the purpose of having conversations like this, so that those of us that haven't seen huge swaths of COVID can learn from those that have. It's going to be a little bit like that with the public, and a little bit like that with goals of care conversations. You know, ultimately, the difference between a doctor and some other healthcare workers is we are paid very well to deal with cognitive dissonance, to deal with the fact that things aren't entirely black and aren't entirely white. And the public, poor things, have gone through a huge exercise in sort of cognitive dissonance, where some people have said in the past, I want everything, please don't even voice any limitations, versus this new one of don't do anything. And I think we've seen this transition in many, many diseases. I've spoken to some Brits because they had such seemingly high case mortality rates, and all sorts of different hypotheses were offered. And one of them actually was, and please take this in context and just understand, as much as anything, it's for provocation. They've said, well, actually, we were finally having the discussions that we should have had 10 years ago, and our case mortality rates weren't extraordinarily high. They were actually probably what they should have been coming into the ICU. So I'm with Anand on 99.9% of things that we shouldn't be rushing towards do everything, do nothing. But it's actually no different than every disease that we've ever faced. This is just the awkward, excessive cognitive dissonance of getting used to a new disease.
Mm-hmm. No, great point.
I want to share and know what is your experience and impression in terms of the drugs, medication that we used, because in the beginning, I mean, with having all these patients arriving, and we treated them. We had an average treatment for everybody, but with days, with time, we tried to recognize, for example, we gave more anti-inflammatory drugs like steroids after diagnosing hyperinflammation, or we gave anticoagulation after we had elevated the dimers. And I think this worked out well, because in the end, after a month or so, each patient had a slightly different therapy, let's say, not all average. We tried to recognize what phase of the syndrome the patient was in. What we gave to everybody is hydroxychloroquine. Yes, we did. Everybody was put on that, and we didn't have much side effects from what I can see. We didn't use antivirals because we didn't have remdesivir. We used the Caletrol, opinavir, ritonavir in the beginning, just in the first week, I would say, and then quitted that. So this is my impression from the drugs point of view.
Mm-hmm. Well, thanks for that. Actually, sorry, Hayley, you look like you got something.
Say, if it's all right, I just wanted to say as well, in line with the same comments, I think that we saw sort of an evolution in how we were treating people. And I feel like in a weird way, and I'm not suggesting this is what you were describing, a lot of it was very reactionary. So everybody got a whole bunch of stuff up front. And we had a protocol, and it was very clearly laid out, and it was very clearly not followed, and everybody got a whole bunch of stuff. And then I think at least those of us in the ICU sort of said, well, we're seeing a lot of folks who are having potential complications from this stuff that may have been just related to the disease, right? But we were seeing a lot of, I can personally attest to a number of polymicrobial pneumonias, polymicrobial bacteremias, and I'm not saying we never see that in other patients, but really very many more percentage-wise. And so I think a lot of us sort of said, oh gosh, these anti-inflammatories are not a good idea, and then we stopped doing them. And so to me, it was, as you guys were just describing with these goals of care conversations, really casting a light and magnifying something that I think we do all the time, which is we're evidence-based practitioners in theory, but a lot of what we do is very reactionary to what we see around us. And I think now we've sort of settled into a place where we're doing a little more of what you're describing. We're certainly tailoring therapy a bit. I think all of us have very different opinions within our group of how we should tailor therapy, but I think each of us is doing a little more of that. But I think all of us have taken a step back and said, let's really not use this stuff, and let's try to enroll them in studies if they're willing to participate, but let's try to gain some information, because I think that we just sort of saw that rapid turnaround of, oh my gosh, give them everything, we don't know what to do, to, oh my gosh, maybe we're causing harm, give them nothing, you know, and that sort of trajectory.
Mm-hmm. I could read Dave's mind too, because we're cut from the same cloth in terms of less is always more. But you did get that sense. Like I was there for the first case that came in through the general, and I feel like they got everything, like, you know, and it was very reactionary, and I mean a lot of it was fear-based. We didn't want to screw this up. But man, it was, as you mentioned, Hayley, like through the kitchen sink.
I think a lot of our rapid intubation was from being exposed. But Hayley, can I ask you for your expertise? You mentioned secondary bacterial infections, and you know, the 1918 flu. That was the belief that people died of strep and staph, even though we couldn't test for it. What's been your practice with empiric antibiotics? Because as you point out, our stewardship of antivirals has been a bit dodgy. What about our stewardship of antibacterials?
So I will preface this by saying, I think it's a great question. I'll preface this by saying that I don't think we have a consistent answer in our institution, let alone both our institutions. I think almost all of us are still doing antibiotics for a couple of days when they present. And you know, we're fortunate, I think, compared to our general medicine colleagues, right, in that we have a pretty good access to their respiratory secretions. So we get a pretty good sample pretty early on. And I think most of us have removed the antibiotics within a day or two if everything doesn't grow. I think we're getting into some more trouble, and I'm really struggling with this because I consider myself similar, Dave, to what you're describing, as kind of like a less is more kind of person. We are seeing a lot of recommendations to sort of throw antibiotics back at them at the slightest thing. You know, the fever 5 days later, the new white count, all this sort of stuff. And I think it's in part because of the number of additional infections we saw. We have plenty of folks who received a lot of those anti-inflammatory cocktails and went home and did fine, right? But then I personally can think of 3 or 4 who've had recurrent bacteremias and pneumonias with multiple bugs, including fungus, which, you know, just your normal person who comes in with ARDS and septic shock, I just don't feel we see that much of. And so I think we're being pushed, we're pushing ourselves to maybe treat first and ask questions later. And I don't love that approach. So yeah, I would say I think we're using antibiotics a little more freely than we normally would, antibacterials. And I don't, similar to what I was saying about the other stuff, I'm not sure if that's good or bad, honestly.
Actually, I'm really curious to hear from maybe actually anybody in the panel. I don't know if we saw a lot of bacteremia. Like, I mean, I'm just thinking of my cases personally. Maybe Dave, did you have something consistent?
Well, what would see is the high fevers, and I think it was the fear that we're missing something else, that they would seem to defervesce, and then you would get this spike of fever, and you're like, oh, I guess we have a secondary infection, and we actually didn't get the bacteremias that positive. It was like we would do a ton of extra cultures, we would add the antimicrobials back in, and then be disappointed that nothing grew out. And I guess we then would, or at least personally, I can't speak for everyone, but often we would stop it. And then next thing you know, a couple of days later, another fever, and you're like, oh, did I miss it? I can recall a patient changing all central lines multiple times in the same individual, just worried that I'm missing something. And maybe this is a reflection of the COVID itself causing the fever, as we know it will cause. But it's when they're so unwell, so sick, I think it's the fear of doing nothing. Sometimes the best thing to do is do nothing, but it's often the hardest thing. And it's not just us. I mean, we have staff that are scared with what's going on, and you get the impression you got to do something. And so certainly we were aggressive with that. And is that a good thing or a bad thing? And I think it's the after COVID, when we do a look back at this and get larger data points, we'll have a better idea what were we doing right and what were we doing wrong.
Tommaso, Bram, did you guys see much in the way of bacteremia?
So our policy for antibiotics in our unit was from the beginning not to start antibiotic until we have a positive culture. And with this, in the beginning, yes, we had a very high fever and still we didn't treat them until we had the positive cultures. I would say that for those patients that recovered fairly fastly, let's say with 7 days, 10 days, we didn't have much bacteremia and VAP, let's say ventilator-associated pneumonia. Instead, for the prolonged weaning, yes, we've seen a lot with multi-resistant bacteria and with bacteremia, yes, MRSA and Pseudomonas and Stenotrophomonas, yes. And but we kept on treating the new positive culture and wait for that. But I would say in our experience, for those remaining prolonged ventilation, with prolonged ventilation.
Yeah, our volumes were never incredibly high, so I can't say I remember seeing a ton of bacteremia. I mean, just because they were so prolonged with their ventilation course, we saw some VAP in some of these patients long-standing. And, you know, especially because their x-rays were so abnormal, sometimes I would have had a lower threshold to bronch some of these people to get lower respiratory tract samples, but we really had been trying to avoid doing bronchoscopies in these patients, so maybe I would have had a sooner threshold to treat for suspect VAP, even without lower sampling.
Mm-hmm. Thanks for that, guys. Doobay, you
I was going to say almost the same experience of we did not have Hayley's experience at all. So I would say we did have a few VAPs, but not multi-resistant unexpected things. Like we had a couple staphs, serratia that prolonged ventilation a little bit, but just like Tommaso was saying, it was really the patients that were ventilated for 18, 19 days. We did have a few bacteremias. Most of those patients are patients that we transferred to the general for consideration for ECMO. So they were the really sick ones. It didn't seem to be out of the ordinary for our ARDS long stay patients, I would say. So nothing new. And the shocking thing about all that is we actually treated all our patients with ceftriaxone for 5 days on admission, which probably doesn't make a lot of sense. But that's what we chose to do in the beginning. Just, in the same way that you treat a PCP patient with ceftriaxone, because you can't exclude that other infection. But, it's based on nothing, right? Like we said, it's based on, we better just do this in case. And then we would universally stop them all at 5 days, but not at 2 or 3 days if there were no cultures, which, you could argue that would probably be more sensical. But we, despite the ceftriaxone for 5 days, we still didn't really see a lot of that bacteremia and VAP.
Well, thanks for that. There's some questions coming in, and I think we could get to them sort of. So the risk factors we talked about, we saw a lot of diabetics, hypertension, obesity being some of those risk factors, comorbid, age, because part of the media's one of the fears that I feel like the media was implementing is like anybody could get this, anybody could get sick. Well, obviously it's true. There's going to be outliers in any disease course, but maybe in terms of your experience, were you seeing cases that weren't really fitting the profile, or was this kind of, were the patients that did poorly, was it predictable in your mind?
I can start, I guess. I would say that all of our patients that came in initially were the same. They were almost the same, 7 to 10 days of symptoms. They would start off at like 45%, 50%, 60%. And then you would know at around day 5 or 6 whether this is going to be a bad one or not a bad one. And it would be, up to 85, 90 PF ratios under 100. But at the beginning, there's certainly no way that we could have predicted it. And even looking back at the data, looking at age, comorbidities, anything, the frailty scale, all of the comorbidity indices, there was no way that we could predict for sure. That's what I would say based on our 30-ish patients.
I think similar was our experience. I do think that there was an underrepresentation of the frail and elderly in the ICUs associated with this, even though they are the most at risk. And I think it was because some of these goals of care discussions and the media portrayal, these decisions were made in the retirement homes and nursing homes, or even on the hospital wards, not to go to critical care in the setting, which might have been different otherwise. So it did seem like the predominance was sort of the middle-aged, hypertensive, slightly overweight. This was definitely the demographics that we saw most commonly in the ICU, but I don't think it's because they were more prone to getting sicker than the elderly and comorbid, but rather I think that they were avoiding burdening the hospitals and ICUs in those demographics.
Yeah, I would build on that because the latter patients that we were getting were more elderly. And I think that's because people were more receptive to bringing them in and providing care. Because I do have concerns on how restrictive it seemed initially on with the long-term care facilities and things. And, I think if everyone was reasonable in goals and expectations, it would have, been more receptive. But we did see an increase in age as we progressed in it near the end. I don't know if others shared that experience or not.
So in Lombardy, if I can, in the beginning, there were, I can say, cities or towns or hospitals that had to decide to put a limit of age for intubation because there were not enough beds for everybody in the ICU. And we had a very early intubation strategy in Lombardy for sure. So I'm not saying that elderly people were not intubated, but I'm saying that from day to day, not as a general strategy, some of the elderly were not intubated and were put on palliative, let's say, care and accompanied to die. Indeed, this could be a bias in our mortality because the age of our population can be a little lower than other centers or other regions in the world, I think.
Peter, sorry, go ahead, Hayley.
No, I just wanted to say in reference to the types of things that Bram was discussing before, I think this is part of what's incumbent upon us in conversations like this, just to remind everybody, right? It's really hard to compare these types of things, as Massimo was just saying, around the world, because the needs of the population really depend upon what's available for them, right? And if the hospital is overwhelmed or other things may be going on, there may be less opportunity for them to receive care that they might otherwise receive. And then I think obviously the sort of cultural norms, for lack of a better word, of what people expect at the end of their lives, and it varies quite a bit around the world, and even amongst countries like ours, which are otherwise much more similar than maybe other countries around the world might be. So.
Agreed. Great point. Peter, you were unmuted. Did you have something to say, or did you? Just want to make sure I'm not ignoring you.
Well, you're terribly kind. You're certainly not ignoring me. I think this is a fascinating discussion about who comes to the ICU, both globally and age-wise. There's going to be some very interesting studies. Obviously, there's going to be a million PhD theses that come out of COVID, but one that needs to be looked at is the 1-year mortality of the elderly, not the 28-day mortality of the elderly. I don't want to live in a society that universally says you're not coming anywhere near an ICU because because you're in a nursing home that's in lockdown or because you've hit a certain age. But I equally don't want to live in one that won't address those kind of issues. So to me, one of the most interesting things that's going to come out of COVID is this idea of excess deaths or even non-COVID, COVID-related deaths. In other words, the MIs, the strokes, all of the other stuff. My understanding is the data that came out of Ebola, which is admittedly a very extreme example of a viral contagion, but 3 to 4 people were dying of non-Ebola related deaths rather than the Ebola itself. So I'm concerned on a social emotional level about what's happened to my hospital and how we deal with end of life issues for everybody now that we're in this sort of relative lockdown. That's bothered me greatly. But I'm also very interested to see data on strokes, data on MIs, data on other sepsis. In the same way, economic disaster may cause just as many deaths as COVID does. There's a heck of a lot to discuss beyond even just ventilator strategies.
Well, Peter, I think we have a lot of, in my opinion, clout to comment on these things because we're front lines. Like everyone's like, you're getting all those on the media, all those like thank yous and whatever and what have you. But like, we're the ones that are at risk, and you're hearing this conversation from many intensivists or frontline staff saying like, are we thinking about the secondary consequences? And I think this is a legit concern. Like I did an interview recently talking about a patient that presented very late for an infection that was on paper treatable, and just because of the fear of COVID. And we've had this conversation also with Dave, and too, I think we might have slightly differing opinions on how this will look in the data, but we're certainly looking at this now provincially as a project saying like, you come in with your COPD or your peripheral vascular disease during a pandemic, what are your outcomes? And from my anecdotal and bedside evaluation, it seems like things are worse based on those fears. So it's something that, like, I think we need to have this conversation for it to be addressed. But yeah, actually, Dave, it might be a good point to bring up the point that you often make.
And certainly, I'll preface it before I make my statement that I've been advocating that we increase activity because I'm worried. I share the concerns Peter and others are alluding to of not doing anything is going to harm other patients with non-COVID disorders. And Quad knows my bias is, I've not seen a marked spike in mortality. Like you'll remember the cases that were late presenting, but we're not seeing a ton of cases late presenting. And I'm actually, there'll be a day of reckoning if we suddenly see the mortality of various regions during the shutdown and less elective activity and things as such. If the mortality actually has gone down, it does raise the question, are we causing harm at times? And so there's a happy balance. And unfortunately, I think we always practice in a world of polar extremes where it's always everyone gets a procedure, no one gets a procedure, everyone comes in the ICU, no one comes in the ICU, everyone gets hydroxychloroquine, no one gets it. I think we don't like to think anymore. We all want an algorithm, but it'll be interesting when we do the deeper dive, and I think we'll be surprised by what we find, that perhaps we can do better in the future.
So getting to more questions, unless anyone has more to say about that. In terms of like one of the things I'm fascinated about is alluding to your point is if we could be more personalized with care, like knowing, based on XYZ risk factor, you're likely, the fact that if you have XYZ risk factor, you're more risk of succumbing to COVID. Like I would like to see more research along those lines. And one of the questions that came up was, in terms of research dissemination, like we've actually seen some negative impacts of things coming out too early, but there's also been some positive impacts by us being able to find out some of the experiences that people like Tommaso had in Italy. And so just amongst us, is there any suggestions on the best way to do this? Because and another point too, it is kind of sad, like in 2020, that more information or more data isn't readily available. Like imagine if you had, I know there's privacy issues and all that, but like a readily available data throughout the world, patients having COVID, and you have like patient level data, vent strategies, all these things that could be uploaded into a database that we could all kind of interpret and have access to. You'd think that wouldn't be impossible in 2020, but regardless, any thoughts in terms of the best way of getting knowledge out as something like this is happening?
Well, I think you've exposed the fact that the traditional scientific method, as admirable as it is not necessarily fit for task when something sudden like this hits. Mm-hmm. So obviously we need randomized controlled trials, and obviously we need to be patient and step back and not rush in and do rash things, as has been pointed out. But I think the role for big data to answer these sort of evolving questions has been exposed by this. I mean, Dave is absolutely right. We make the fallacious assumption that what we do must be beneficial and the lack of us must be detrimental, and it might absolutely be the other way around. I mean, I'm particularly fascinated by risk factors because a lot of the risk factors in my center were simply people who had status Americanus, people that were obese, hypertensive, et cetera, and these aren't really traditionally called risk factors. The average BMI in my province, and I'm an exemplar of this, is about 28. So we talk risk factors versus is it just being a typical patient that is sick enough to need an ICU? That's your risk factor, and everything follows from that. And I think big data is needed for this sort of thing as we fumble around in the dark.
So I want to say something. I promise not to defend Americans in response to that.
Well, status North Americanus then, because Canada's no different.
Fair enough. So I think, Claude, you raise a really interesting point. I think obviously this is for those of us who like to play with big data and think that we do it intelligently. This really has seemed like a missed opportunity, and I think we've queried that many times, right? Where we're wishing there was more readily accessible data. And I think on the whole, that is absolutely what we should aim for. I think there's some potential risk in that, and to me, that unrelated to patient safety issues, which obviously exist, but which I think then plays into your second question, which is how do we handle these things coming out now? And I think that relates back to this issue from before of how is this data misinterpreted or interpreted, and might that be wrong? And so I think part of the issue with having data available to everyone is policing how that data is analyzed. And I don't think that's the responsibility of the individual researcher necessarily, because he or she may think that they are very apt to do things correctly, whatever that might mean. But I do think that that puts an enormous onus upon peer review and the editorial staff of journals. And I think that if that's going to be how we continue to disseminate information, and I've struggled with this a lot, handling some papers for one of the journals with which I work, I think that we can be more forceful early on in an epidemic with insisting upon limitations, real limitation description in the data that's being presented. And I think that may get us around some of this. Obviously, there's going to be a news outlet that picks up that single number. But I do think if we ask of ourselves as researchers and of our researchers as reviewers and editors to really outline where the deficiencies are, not because they've done a bad job, but just because of the timing that the study is being done in. I think we would be doing ourselves a big service. And so if we're going to open up data to everybody, we need to be even more strict about that. That's my opinion.
Yeah, I think that's a fantastic point. Sorry, Bram, I thought you looked like you were going to ask a question. I was reading your mind.
No, I did have some that. I just didn't know timing wise if that was acceptable. But if I have a minute or two,
do it.
I was just going to say that I think that there's the science part of it, but then the media and platform plays into this so much as well. Is that, you know, inevitably you're going to have good science and bad science, and rapid. I completely agree with Peter. Is that well done, methodologically rigorous science does not lend itself to rapidity, but there is going to be stuff that is better, more well done. And I think that, you know, taking every opportunity to give the proper scientists and experts the pulpit, and policing our media and journalists in terms of avoiding giving false prophets that pulpit. And, you know, and that's why I've tried as my best, as Anand has and others, Quad, Peter, and I don't know about the others, but, you know, every opportunity you have where media engages you and says, do you want to write this article or this opportunity to go on TV? We need to, as, you know, the quasi-experts in this field, take all those opportunities and dispel misinformation and propagate accurate information. Some of it falls on us, it falls on the media, it falls on our leaders, our public health, and our Justin Trudeau and Donald Trump and all others to sort of fall back on science and push forward those that know what they're talking about and push down those that don't know what they're talking about.
Fantastic point. And especially in an era where, you know, it's easier for us to express ourselves, like with Twitter and Facebook, YouTube, what we're doing now. Like it's, you know, I personally feel like I'm a bit on a mission. Like for me, it was more on the overall just doom and gloom of COVID, and just adding that point that, you know, it's crazy. People get sick, but most people don't get sick. And, you know, and we're doing okay. Like, let's talk about some of the wins. Let's talk about the fact that, you know, our ICU might not have any COVID patients right now. Like, let's talk about some of the upside. Let's talk about maybe giving some of the power back. Like, one of the narratives I would love to see is, you know, if there is a lull this summer, people get healthier. You know, like start getting that exercise, start getting that weight loss. Like, you know, maybe that should be a narrative that gets pushed. But Bram, I honestly, I think it's been more important than ever to us to be champions of reliable, balanced information.
Yeah, there's definitely room in our specialty for sort of professors of the public understanding of science, and we haven't pushed that enough. You know, we focus so much on published opinion. There's also public opinion as well, and we're only just dipping our toes into that. Maybe that's one of the good things that'll come of COVID. And you know what? There are plenty of potentially good things that could come from COVID, including the fact that I've learned you don't have to be flying to a conference every second week. You know, a lot of the stuff we did was self-important, self-aggrandizing. So any dialogue we can have, as Bram has pointed out, with the public, we should leap on that opportunity. And that's a new skill set we all have to learn, and we should take pride in learning it.
We're in a bit of a unique situation that there's a highlight on our field right now. Like people who are not in our field are so knowledgeable suddenly, well, knowledgeable relatively speaking, about ventilators, about critical care. You know, people are, you know, seeing the media appearances and what's happening in the ICU, and I get all these comments like, wow, you guys are really doing great things. And I want to be like, that's what we've been doing for many years. It's just everyone's paying attention now, and we're at this unique opportunity where we can start to actually, you know, socialize things like goals of care and what ICU care is like and what it's like after and what it's like during, and not just, you know, maybe wait for that that time when the patient's about to enter the ICU to educate the entire family about what that means.
No, that's
Brilliant.
beautifully put. Adversity is a terrible thing to waste. So if we lose this opportunity as a profession, it's our own downfall, and our patients will suffer for it.
100%. This is the push that the Solving Healthcare Resource Optimization Network. This is why we're pushing. This is why we've done 6 webinars, and I don't know, Dave, you've led about 4 out of the 6. Just pumping out content, and I would love. I mean, this is biased as a palliative care doc too, but if we had that more that open dialogue about end of life care and all that, like even if that came out of this, like, wow, like that's a big win.
Quad, you're fighting the good fight with these podcasts and with helping with information. I think it's appreciated by many.
Oh, appreciate that, buddy. Appreciate that. I'm just getting a second to peruse. We got about, I'll say about 5 minutes, and there's a couple quick hitter questions. Dave, I think this one's best for you. Did you have a sense of what percentage of COVID? I'll put it this way: hospitalized COVID patients ended up in ICU locally.
I think we're higher than in the ICU. I think it's higher than 5%. That's commonly quoted, but I can't give you as accurate numbers for that. But I do believe we're higher than the 5%, and I think that was trying to keep more people quarantined out of the hospital. So I would say higher.
Okay.
I can tell you that our hospital, it's between 30 and 40% of patients that are admitted end up in the ICU at some point.
Cool. Couple other quick hitters. I think this one may be best for Peter. The fact that you had low incidences of COVID, you mentioned that you think that maybe you might get harder hit in the fall. Is this affecting how you're going to your ICU will prepare, or is it more of like see how it plays out kind of approach?
Well, it's a great question. It's one of the reasons I'm so interested and or concerned about this excess deaths and non-COVID related, because it could mean that we never actually step down the precautions. And there are aspects of this new normal that are good for us. You know, the fact we live in the so-called digital age where we're constantly washing our digits is not a bad thing going forward, and increased use of masks is not a bad thing going forward. But this is why I fear that we may implement this as the way we do things now. In other words, one disease dominates all others. That's my concern with us not having had a peak, as bizarre as that comment sounds.
Mm-hmm.
You can flatten the curve, but I don't believe you can extinguish the curve.
Mm-hmm. Yeah, and I do wonder if a lot of our approaches are, is it truly flattening the curve nowadays, or is it like the falsity, whether you believe it or not, to try and rid the virus? Anyways, that's a bigger question actually. So I'm going to skip that. Are your ICU admissions driven by needing to coordinate patients? Oh, wait, sorry. Let me just double check I got that right. Is the lack of private and negative pressure rooms on the floor affecting your ICU census? Like, are you bringing more patients down to the ICU because of the lack of negative pressure rooms? Never. Okay. Because I think...
No, and I would only point out that I don't think you need negative pressure rooms to safely manage COVID patients. Like doing the deeper dive in the PPE stuff, the more if you actually look at the evidence that's out there, we're afraid to accept evidence sometimes for some of this. So I don't think you need the negative pressure room. So I would agree that it's not driving ICU admissions.
Perfect. So any last thoughts or comments or things that any of our panelists feel like we need to address that hasn't been addressed?
I would add that everybody has an input here, and I'm very, very grateful for the people who have taken the time out and listened in to us, because at times we have absolutely no more expertise and probably less than some of the people listening in on the line. This has been a profound social experiment and social upheaval, and a lot of people are suffering through this. I don't mean to sound cute or trite, but honestly, my heroes through all of this have been the people who've driven the buses and made the sandwiches, because you and I live in a world of uncertainty and we can deal with that. You and I have had PPEs, etc., etc. So I would just extend my best wishes to everybody who's on the call, and equally encourage them to reach out to non-traditional heroes. I'm very eager for the banging of pots for healthcare workers to end, because in many ways we're actually very lucky. We have reliable income. In fact, as Anand pointed out, we finally have the spotlight shone on us. People are saying lovely things about us instead of assuming that because it's summertime we're at the golf course. So I would just extend best wishes to everybody out there, medical and non-medical alike.
That's a great shout out to Peter, and I'll even reinforce some of the allied health too. Like you're hearing more about the personal support workers that have succumbed to COVID, and it could be. I mean, we can't do our jobs without them. The respiratory therapists that are right there and really at high risk. So I'm glad you brought that up, and just want to extend that to the rest of our team there, allied health, physio too. They could be forgotten. Anyway, guys, cleaning staff, of course. Yeah, cleaning staff. Thanks for that, Dave. That's, what an intimidating process. You want to say? You look like you're going to say something.
Well, no, I was going to say we go in with all the stuff, all the knowledge, and then we make a mess, and then we walk out of there. And I think a lot of the COVID that's shared isn't so much airborne as everyone's concerned. It's picking it up off of equipment and things like that, and we make a mess of the rooms. And it's the cleaning staff that actually go in with. No one's probably sat down and spent time educating them on what is the most important thing. And so, we could do shout outs to a lot of people, but I think they're the forgotten people in all of this.
Amen, brother. All right. Thank you, panelists. Thank you so much for this. I'm going to put you on a job, though. This is going to be ready this time tomorrow for podcast and YouTube. Circulate it to your academic staff. Circulate it to your everybody and their mother, because once again, I want us to do our part to make sure people are informed in terms of decisions when coming to admitting our ICU COVID patients. But once again, thank you so much for doing this. This was excellent.
Thanks for organizing. Thanks. Great.
For organizing.
Pleasure. Thank you. Great organization.